Good afternoon. It's THCB gang for, whoa, I have the wrong date. It's not April the 1st. It's April the 15th. I'm Matthew Holt, founder, publisher at Bodybuilder on Twitter, founder and publisher of THCB, and really excited for our show today. We have a small number of our usual gang members and a very special guest. On with me today, Rosemarie, CEO of Day Health Strategies, author of Marching Towards Coverage. Vince Kuraitis, veteran health IT consultant, policy analyst from the wilds of Idaho, and my old colleague and buddy, JL Neptune, these days running Suntra Modern Recovery, but one of those MDA, MBA types who annoyingly, is running healthcare these days. And then our guest, who we'll say a lot more about shortly, is Robert Pearl, author of a new book called Uncaring, which we'll talk about a little bit in this session, although I will also separately interview him about that elsewhere on THCB. Most famous for running the Permanente group, obviously the Kaiser medical group, for nearly 20 years, basically for end of last century, most of this. So here's the gang. We are going to go live and see how everybody is. And the way we start this is the way we always start this, is by going around the horn and asking people what they've seen in the last couple of weeks that's poked their attention and piqued their interest. And I'll start with you, Vince.
Yeah. Hey, Matthew. Matthew, you and I have known each other a long time. And,
how could that have happened? I'm like 26 years old.
And I think we've always shared a certain skepticism as to whether the healthcare system does things for the benefit of patients or whether it benefits itself. And so I'm picking a topic that I'd like to share, and I'm particularly piqued since you have Dr. Robert Pearl and his experience with medical groups. Telehealth, it's boomed, and much of this boom has been due to the relaxation of federal regulations, CMS stepping up to the plate to reimburse in parity, allowing reimbursement for audio, states having loosened cross-state licensure, and relaxation of HIPAA regulations. And every one of these are still in place today. So in light of this, I've always had this suspicion or question, how long will this last? And I'm going to read to you from a tweet from a colleague she is a telehealth implementation consultant, and she is quoting a physician department head speaking to another group of physicians. And it's a paraphrase. Okay, here's the paraphrase. Bring patients in person to clinic. Don't do telehealth unless patient insists. We're on RVUs. We lost enough money in 2020. Clinics are open. We make more money in person. Of course, this is something we would never, ever expect to see in our patient-centric healthcare system. So I'll pose the question and sign off and ask, is this a one-off, or is this sort of the whispering winds of the imminent hurricane that is going to occur, particularly in light of the fact that we believe that much of these regulations that I've mentioned are not likely to persist once this pandemic is over? Thank you.
Fascinating question. All right, JL, you probably have some opinions about that particular thing, but what else have you been looking at this week?
So I'll say two things. One, first, for those of you who are familiar with the Wu-Tang Clan and their hit CREAM, which stands for Cash Rules Everything Around Me, I think healthcare is run like any other industry, and it comes down to profitability and, profitability on a per square foot basis, on a time basis. And I think that is a very severe problem, or I wouldn't say quite insurmountable problem that we're going to face, but as long as the same incentives are in place, and remember, those incentives exist at many different levels, right? At the individual provider, at the hospital, at the health system, at the payer level, it's going to be very difficult to get people to change their behaviors. And I have many friends who are still, seeing patients in the clinics who are telling me that they're feeling pressure to bring patients back to the hospital and to be seen in person. My hope is that patients and healthcare consumers have become accustomed to the virtual life and how good the virtual life is, and will be a counterbalance to that pressure to bring patients back into the hospital. But again, cash rules everything around me, and you got to figure that that's going to happen. happen. So that's my comment, my retort to what Vince had to say. And then I'd say of note, Microsoft announcing that it's acquiring Nuance Communications for $20 billion sort of takes me back to the Health 2.0 first conferences, right? When Microsoft and Google are talking about big things that they're going to be doing in healthcare. And it seems to me that what is old is new again.
I have to interject. I have an original version of the Wu-Tang Clan. I'm offering it as an NFT for $3 million. If you'd like, $3
million, $3 billion.
We're having the auction. We're having the auction right now. I still don't understand what the hell the NFT is, but we'll figure that out. All right, Rosemarie.
I think the pause of the Johnson & Johnson vaccine. So I'm really focused on vaccine rollout and the fact that, we were moving toward in our state of Massachusetts, but I think this is true more across the board, that really everybody's going to be eligible. And we were looking at, a really decent amount of supply. That is, of course, being affected by the pause. But more importantly, I think, is the psychology of getting folks vaccinated. And that's where I think about the health equity issues, because we know about vaccine hesitancy. Right now, we've got a surge of folks who, the demand is going to exceed supply for a bit. But then we're going to have issues of trying to get the folks who were, as I say, hesitant, and just getting this word out about, especially the one and done shot, which in fact, in conversations I've been in, we've been thinking would be really good to bring out to populations that are harder to reach, because then you don't have to try to reach them twice. I mean, it's kind of basic. And this is really troubling. So that's what I've got my eye on.
Robert, before we introduce you as a guest, just give us what you've been looking at the last week or two that's piqued your interest.
I've been looking at many of these issues, as you said, with my book on caring, how the culture of medicine kills doctors and patients, coming out, all profits going to Doctors Without Borders. These are the issues. Telemedicine. Why? There you go. Why is it that the dollars do rule, but what about the culture? How much do physicians believe that better care is provided in the office, when what we know is that telemedicine can allow immediate care, and by reaching out immediately and solving the problem, it can raise the quality. It was about 7 years ago that I published an article on Health Affairs, talking when I was the CEO in Kaiser Permanente. We were doing 14 million virtual visits, and the rest of the world was at 1%. I worry about the equity. I think about that. And there's a major chapter in the book about racism. We tell ourselves we treat everyone the same, but what do we see? When there was a shortage of testing kits early in the pandemic, white patients got tested twice as often as black patients. They got 40%, black patients got 40% less pain medication. We go down the list of things that are there. I think the culture of medicine and the system of medicine both have to evolve simultaneously. And that's what I spend my time around. And I'm particularly worried now in the COVID-19 situation, that when we're looking at things like vaccination, that is the way out of the problem. We're seeing all the same issues doubling up as the problems and the shortages exist.
That's it. Well, I'll give you a couple of things I noticed this week. First is that Agilon went public today, which is yet another of these wraparound MSO Medicare Advantage medical group types. Valuation now $10 billion for that company. I keep thinking, because you'll hear about it, what would happen if Kaiser spun off the medical group and took it public? How much would it be worth? God knows. So that's one thing. The other thing I noticed was that there was one of these other lists that came out today, something called the Health Technology Management Report, which had the 50 top CEOs of health technology companies in America. There was a certain Judy Faulkner who was not on the list, which I thought was pretty interesting, given Robert. Anyway, but let's introduce Robert a little bit more. We met a bunch of times when you were at Kaiser, and I want to talk a little bit about what you did there and some of the changes you made, some of the things that didn't happen at Kaiser, because that's a little bit what we thought about. And obviously, there was a management change on the health plan hospital side while you were there. George Alverson retired, and Bernard Tyson, God rest his soul, took over. But there was some big changes to that. And then obviously more recently, you've been a sort of an advocate, an author, a publicist, a podcaster yourself, an avid writer. You write in Forbes elsewhere, and written a bunch of books, including obviously latest one on caring. I do want to start with I'm a little bit way through on caring, and I noticed that you start with the discussion about Semmelweis and hand washing in Hungary, was it Austria, and the fact that he basically told all the other doctors that they were doing it wrong and that they were all terrible people. And I'm a bit worried that you're doing the same thing. And I'm sort of hopeful that you don't end up with the same fate, because those you don't know, Semmelweis died in a mental asylum, having gone insane trying to persuade other doctors to actually wash their hands, even though we all know now. And you mentioned in that chapter, it took, 80, 100 years for that to become like widely understood amongst doctors. And so how hard culture is to change. But let's step back a second and talk a little bit. I remember meeting you in DC at a small conference in the Kaiser Center there, and you were basically discussing the success of Kaiser in Washington, DC, in the Mid-Atlantic group, and how well they'd done without owning a hospital, and how the medical group had basically figured out how to take care of a population. All the sort of troubles and tribulations of the 80s and 90s of Kaiser were kind of over. You now had the Epic record. There was information flow. You were started doing these virtual visits and communicate, 24/7 communication. And, you said to me, there's no reason why this can't go nationwide and Kaiser can't go nationwide. And yet it didn't. So was that politics? Was that internal stuff at Kaiser? Was that because the market wasn't ready for it? Why haven't we seen the spread of those kinds of systems to the rest of American healthcare?
Thank you, Matthew. Let me offer two sets of thoughts. The first one about the Mid-Atlantic, where it has grown from 400,000 members to 800,000 members. It actually, last year and this, led the entire country on the NCQA quality evaluations. And it's an organization that now has 10 applicants for every opening. So I think the success that we talked about when I became the CEO, not just on the West Coast, but the East Coast as well, has played through in that marketplace. But you're raising a very, very important part. And if I communicated that Kaiser Permanente was going to dominate, that's not what I meant to communicate. I think that the system of care, moving from fee-for-service to capitation, and with capitation now bringing, and I'm talking about the delivery system level, not at the insurance level, bringing physicians and hospitals together, figuring out ways to provide better care, including technology, is what's on everyone's mind who's looking at healthcare today. So the question is, why not? And my answer would be, number one, that it's easier to do more than to do better. And physicians and hospitals do better in a fee-for-service world. One of your hosts mentioned the fact that you can bring people back to the office and generate more dollars. That's what exists in a fee-for-service world. And so people are clinging to it. And I think that the patient, as the consumer, has just not had a major voice, as you know very well, regardless of whether you're looking at the specialty groups, the pharma world, the hospital, everyone's doing well, except for the patient, and overall, I think, for the United States. So it's how difficult it is. You mentioned George Halverson earlier. Right around that time, what I didn't say to you is that George and I were meeting with Mayor Bloomberg in New York. And I think that had we done that and been able to bring along the massive population in New York City, we might be having a different conversation today. There were politics in New York with term limits. As you say, there was some politics inside Kaiser Permanente. It didn't happen. When you look at the failures of Kaiser Permanente, though, what do you see? Whether it's Texas, Kansas City, North Carolina, you saw an attempt by the health plan to contract with physicians in a fee-for-service world. And if you're 10% of the patients, they're still going to practice the way they were. The places that have moved the Kaiser Permanente true model of capitated, integrated, technologically enabled, and well-led care, I think have done exceedingly well. And again, if we fast forward 7 years, the reputation of Kaiser Permanente is far better than it was certainly when I started, and far better than even 7 years ago when we were speaking.
So when you think about that, you say, okay, it doesn't have to be Permanente group. It has to be that sort of capitated medical group at risk. And then you obviously get the incentive to figure out, well, is it cheaper to have people stay at home and do a video visit or do a text message or whatever. And you've seen a lot of that pick up still in across Kaiser in different ways, right? They're different. There's not one vendor they use for text messaging or whatever it is, but they're still getting their own way a bit. But you also see all these other groups, right? Many of them are now public, but the Chen Meds, the Iora Health, the Oak Streets, Agilons, whatever, who are kind of picking up on the same flavor, particularly around Medicare Advantage. Do you regard them as essentially the same thing and regard their growth as being the same basic principle? Are they just sort of different flavors of the same ice cream?
First of all, I have tremendous respect for those groups. They're doing remarkable work. They're taking care of a Medicare Advantage population that you well know is very sick with chronic disease, and they're providing better quality at lower cost using a combination of technology and system improvement. I think one of the things to recognize within all of that, though, is that the limitation is it's not yet involving the specialist. And that's going to be the next big piece that has to happen. I'm very excited about the possibility of telemedicine impacting that. And I think for physicians, they should be very worried about what's happening in Amazon. I think that if you look at 3 years ago when Haven was formed, I wrote about that. And I wrote the fact that if anyone thinks that Jeff Bezos is only designing Haven for the million employees of JP Morgan Chase and Berkshire Hathaway and Amazon, and it's going to be a not-for-profit, they probably think that all Amazon does is sell books. No, this was going to be in healthcare what it is in retail. I think that telemedicine has accelerated far faster than doctors believe. They may want to still bring patients back to their office, but the opportunity to provide far more convenient and higher quality care. It's not second-rate care, it's better care because it happens immediately without any delay. That's going to happen. And as you well know, they're now going to start leveraging their physicians in different areas to provide care to other organizations. The big challenge in a capitated type environment is having a large enough group of patients. It's why we're seeing so many primary care groups out there. And if instead of wanting to change American medicines by writing books like On Caring How the Culture of Medicine Kills Doctors and Patients, I wanted to make a lot of money, I would start a specialty high-tech organization that would make available to all of these primary care groups across the United States 10 experts in every specialty available to provide care when the patient is in the room. And when we did that in Kaiser Permanente, we were able to take care of 40% of problems that primary care physician would have sent to a specialist, resolving it in the primary care physician's office immediately without the individual missing work or having to delay in getting the diagnosis. It is so close. But one last thing I'll offer, because I teach at the Stanford Graduate School of Business as well as the medical school. When you look at disruption, two things happen. It takes far longer than you ever believed that it will take, but when it happens, it is so much more powerful than you ever could have imagined. And I think we're going to see that in healthcare, whether it's the next 5 years or the next 10 years, I don't know, but it will happen, particularly in the post-coronavirus era, when the economic problems of a government that borrowed $8 trillion, states that have to have a balanced budget, and small businesses that are reeling come to recognize the government can't keep printing money and sending it out to everyone to keep the economies afloat.
We'll see on that last.
If
JL,
I
I
may.
want to bring you in on the, and I go to Vince. JL, I want to bring you in on the sort of the specialty primary care. You live in that New York ecosystem. I know you now are running well, you should say a bit about what Suntra does, and how that works and how it works relative to the primary care groups. There are companies like Rubicon and Sitka and others who are kind of doing what I was talking about, which are at least doing at the moment asynchronous specialty care, but maybe we'll probably move to that live stuff as well. But give me a sense about how you think the primary care to sort of specialty network piece is working out, especially in the sort of non-Kaiser markets, as it were.
Sure. I mean, look, from what I understand from my friends who are senior executives at most of the large health systems in New York, whether that be NYP or Sinai or Langone, specialty medicine drives the profit for the institution. What is allegedly a nonprofit institution relies on tertiary and quaternary care to pay the bills and keep the institution afloat. And I think that, I know the Rubicon team very well. I know Gil Ado very well. I'm actually an investor in Rubicon MD through my work at Blueprint Health. And I've always argued that Rubicon MD is the most disruptive company in the Blueprint portfolio, because what Rubicon is trying to do is make specialty care less siloed, make it more available to organizations that don't have access to it. I think their markets now are correctional, rural environments where there aren't a lot of specialty providers. But I could very easily see an Iora, an Org Street, ChenMed hooking up with the Rubicons of the world and providing specialty access. And that would have a massive impact on, the in-person provision of specialty care. It's very funny that you mentioned that Rubicon and others are asynchronous, because they, as a bit of background, they recruited me at one time to potentially join them. And I put together a presentation that I actually just looked at 2 nights ago. And one of the big things that I emphasized to them was that the contact between the specialty provider and the primary care provider shouldn't be asynchronous. It should be synchronous. You should basically have people waiting to take a call. And it's, as you know, I worked at a company called Gerson Lerman Group. We connected experts to clients who wanted to talk to them. And the big thing that we focused on was trying to get as synchronous as possible. So I very much agree with Dr. Pearl. I think that if you can figure out the technology exists, the systems exist, I think at the end of the day, it comes down to the payment models and what are people's incentives, the incentives of the whole system, do they align in the right way? But I could very much see a lot of specialty care moving to pure virtual, because, so much of what we do in medicine doesn't require a physical exam, particularly if you know the patient, and particularly if somebody else has been able to do a good physical exam for you.
Vince, you're going to jump in, so jump in now, and then we'll go to Rosemarie.
Yeah, I'll echo what Robert said about Amazon. They've got some infrastructure to build out, but I make a prediction. I'm looking forward to the day when we hear an announcement of Amazon saying to its 112 million Prime members, your first telehealth visit is $10. I don't think that's unrealistic. I think it's also a comment of pointing out that the transformation that Robert refers to is truly hard. The integrated systems that we probably think of off the top of our head, the Kaisers, Intermountain, Mayo, Cleveland Clinic, they've been around for 40 plus years. You look at the ACOs, which started around 2012, and one of the things you see in terms of the profitability is and the ability to meet quality metrics is, it's the older the group, the longer they've been in it, the better that they do at it. And the groups that are just entering struggle. This transformation process is truly very difficult.
Do you think that, and this is a question for the group, and maybe do you think that if you can figure out the model, that you can scale it quicker? Now, I say that because if you look at the ACO world, where it's been, we've grafted, and Ian Morrison has his joke about Scouts badges. With the hospital CEO has, I got 3 ACOs on the Scouts badge or whatever, but aren't really doing it. If you think about the people who are trying to build even primary care groups into ACOs, we'll take Agilon, which essentially is doing a management process of the same thing, where they're going to medical groups and putting in the process. Or you take an Aildade, which has done it with primary care docs, a lot of whom are independent, but it's had a lot more success in terms of making savings through its ACO platform than some of the bigger ones. Do you think it's just we got the process wrong and the policy wrong, and we had to include those bigger hospitals? And then if we get it right in the process and the policy, we can change it faster? This is where anyone wants to take it up, but or is it the whole thing? It's medical culture. We'll get back to culture in a second. Is it just too hard to transform?
I don't think it's too hard to transform, Matthew. I think one issue is you can't be part capitated and part fee for service.
Right.
It's too confusing. And so how do you scale to a large enough population to provide the specialty care in a small enough geography is a massive challenge, of which I think that telemedicine will be a big solution. Exactly how, if you combine that with centers of excellence, you start to have a lot of opportunities. You still haven't addressed your local ED and the urgent things that can't be managed at either end of the spectrum that sits there. I also think it's so new. You know, I've talked now to 3 primary care groups recently. They are expanding massively, these primary care groups able to take risk, mainly through Medicare Advantage, having a prepaid structure, and they're fully Medicare Advantage. So they're able to have that kind of focus. And I'm hearing numbers that blow my mind. They're going to go from 100 offices to 300 offices in 2 years, and they already have the capital, whether they have generated themselves or they got it from the marketplace. So I think we're seeing the start of an increase that is going to continue. People understand the model. Making it happen, particularly in the specialty arena, is exceedingly difficult. I think these primary care groups are figuring out, you know, if instead of at 5 o'clock, we send every patient to the ED because our offices are closed, one of us is available out of the 10 of us or 20 of us, it's an economy of scale issue, we can actually take care of most of the problems. And not only is the cost excessive in the ED, the care is not good care because it's not designed to take care of patients with regular problems. It's just simply designed to say, are you dying and need to be in a hospital, or are you not dying? There's no continuity of care. There's no information available. It's not the job they were designed to accomplish, but we're using them because we don't have any other good alternative.
Yeah, let me give one wrinkle to that, which is, when I got going in this business, there were a bunch of smart primary care groups, primarily in Southern California. You knew them well, Friendly Hills, Mullican, all those players. And the stock market got involved, right? Investors got involved. They all went public. And that wasn't the only reason things went south for them. It was a big part of it. And I worry a little bit that you have Oak Street with its valuation or whatever it is, 15 times revenue or stuff, something like that. And you know, these other companies are going public. I did notice that Privia is going to go public, the East Coast IPA-based medical group. They're actually making a profit, which is almost a disgrace these days if you're going to go public. But they were like 90% fee for service. They're really not in that group of the sort of Medicare Advantage or fully capitated groups the way that an Oak Street or a ChenMed is. And I just, are we concerned that the pressure being put on these people by the investor community is going to be too much?
So
Rosemarie blinking. So if you're going to blink and roll your eyes, you have to answer, Rosemarie.
So Matthew, we talked about this a little bit before the call started about how it feels like there's unlimited funding now for new concepts that people think can scale, right? And again, as Dr. Pearl mentioned, there's entities out there that have 100 offices and have enough capital to grow to 300. So I think the market is awash with capital that is looking for innovative, disruptive concepts. And I think that, as we also said before the call started, a lot of these concepts can do irrational things, right? And spend a lot of money to buy market share in a way that I think is very, very threatening for the established legacy players. If you are a major hospital system, I have a friend who does acquisitions for a large health system here in New York. They're still buying primary care practices at a premium. Now, if you're dealing in a world where you have all of these externally third-party funded primary care players that are stealing your lunch, that are eating your lunch, that are stealing your market share, that is very threatening. As an academic system, maybe you don't want to switch out of a fee-for-service stance, but maybe, as Dr. Pearl was saying, I don't think you can be fee-for-service and at-risk capitated at the same time. You have to make a change, and maybe all this capital floating in the market is going to force some of these health systems to say, we just have to take the leap now. We have to get out of fee-for-service. Being in a capitated world is the only way we're going to be successful, and we have to figure out a way to work with these new entrants in the primary care space.
How do we correlate that with Vince's quote about, the chief of staff saying, get all those people off telehealth and back into your office?
When a couple of weeks ago, when I was on with Jeff Goldsmith and Michael Millinson, Jeff made somewhat of a disdainful observation about people who believe that all you got to do is change the incentives and everything fixes itself. And I raised my hand, I'll do it again and say, the first thing we got to do is change the incentives. So yes, there's certainly a risk of VC and private equity backed large physician groups cutting corners. But compare that to the evils that we know of fee-for-service medicine, and where large integrated delivery systems have just dragged their feet for well over a decade. And as Robert pointed out, it's very hard to have a foot in one world or the other. So, as painting a scenario, I think it's very possible that history will write this up as the pandemic and telehealth and technology became the tipping points to push us over the edge towards a true value-based system, one that could not longer be resisted by the delivery systems. And to answer my own initial scenario of where the doctor is standing up in front of his colleagues and saying, bring him into the clinic, that's a case where the market could work. I've seen the statistics that say 1/3 of patients would switch to go to a doctor who offers telehealth. Well, let the market work here.
So, and Matthew, just going back to that doctor, let's call him a department chief or a subsection chief telling people to bring patients back into the office. I mean, yes, part of that I think is physician culture, but I think a big part of that is the CFO, the CEO, and the boardroom saying, "Hey, listen, these are our numbers. We need to get back to more profitable business." But just as that physician can be flogging in person, that physician could be very easily flogging virtual very soon if the incentives change and if the organization embraces that kind of business. And I think I agree with Vince. I think that the pandemic has fundamentally changed, and this is an argument that I'm making to investors. I think the pandemic has fundamentally changed the healthcare consumer. I think it has educated the consumer about how to use Zoom. I think a lot of people were not comfortable using, teleconferencing technology. So now the market is very much of users is educated about the product. And I think that a lot of people now understand that they can access a high quality doctor without having to deal with all the inconveniences. And I think that is a permanent change, and we can try to fight, physicians can try to fight against that, health systems can try to fight against that, but I think that is a market share losing proposition, because I think that now that you have this new psychology, I think there are going to be lots of people who say, hey, you can have just as good of a product available to you virtually. These are all the benefits, work with us. And I think a lot of people will move in that direction.
I like
So let's go to Rosemarie and then Robert. Sorry.
Okay, thank you.
Well, I like hearing what Jean-Luc was saying there, because when you saw my eye roll earlier, Matthew, I was thinking about the dichotomy between what the investors would be pushing for and then what I'm worrying about, which is the vulnerable populations, those that are rural, et cetera, where telehealth can just be this complete savior. And I want to find a way to align the interests so that we can serve the underserved, as well as find ways to, make that a profitable investment. And so I think Jean-Luc is starting to connect some of those dots there. So thank you.
For viewers who want more information, my website is robertpearlmd.com. I have to promote that a little bit, but let me comment.
We don't believe in self-promotion around here.
Exactly. Let me comment a little bit. We've had a bifurcated system. I really want to piggyback on what Rosemarie just said. Basically, we found ways to overtreat people who are wealthy and put up barriers to people who are poor. And in that sense, we've managed to somehow limit the growth and cost of healthcare to 5 or 6% a year, which is ridiculous, considering that that's 60 to 70% over a decade. We're talking now about whether disruption is going to happen. We have several of the panelists who are experts on disruption. It's one of the things I teach at the business school. Disruption is never smooth, easy, painless, or stepwise. This is a totally different way to provide care. The idea that says either we overtreat to generate money in a fee-for-service world, or we put restrictions and barriers up and gatekeepers up to avoid giving the right care is the wrong paradigm. So the question you're really posing, Matthew, is that if we look at this question of what's needed is that we change healthcare so that we can provide higher quality, more convenient care, easier access at lower cost. I was at a site in Oregon at a health policy arena, and there was a sign that said quality service cost at the top, and below that it said pick any two. That was the 20th century mentality. In the 21st century, if we redesign the system, how it's structured, if we can use technology to eliminate distance and time, if we can change reimbursement, provide leadership. I mean, try to think of another industry, 3.7 trillion, that really has no leadership structure. You just don't see these things any place else. It is so primed for disruption. The question for your panelists or for your hosts is going to be, what is it going to take for disruption to actually happen? Will it come from big business? Will it come from physicians and hospitals? Will it come from the consumer? Will it come from Amazon, or won't it come at all? Because disruption is what we're talking about, not incremental transition.
I agree, and I have this whole thing, which was, funny enough, I was on with a VC, who was giving Leonard Keith, who's been incredibly successful, aggressive VC, defined ventures in the last couple of years. Left kind of a one woman plus one man shop, raised $280 million, did 15 deals in less than 2 years. And I criticized her a couple of years ago, gently ribbed her because she'd give a talk about all the things you had to do as a startup digital health company to sell to the incumbent systems, and how you had to go all through their hoops and do all their IRB stuff and do all the clinical protocols. And at the end, I said, I basically said what you just said, Rob. I stood up and said, this sounds great, but you were at Kleiner Perkins. And when Jeff Bezos showed up to talk to John Doerr, he didn't say, I'm going to come in and figure out how to sell, I've got to sell books online. I'm not going to go take it to Barnes and Noble and Sears and figure out how help them to sell more. I'm going to put those guys out of business, right? And do it a whole different way. And I raised that point again in the thing because I was kind of kidding with her. And she's basically now said, yeah, you're right. I'm now invested in people like HIMSS, people in Unite Us, others who do, companies who are really going around the current system and building a whole new system. I think that is the sort of fight we're seeing in the marketplace. All right. We've been talking about this topic a lot. I want to just quickly switch to the COVID situation, which is not solved. And this week, as Rosemarie pointed out, had a big hiccup. So I want to go to you, Rosemarie, to talk a bit more about the J&J, the vaccine, what you think. And then, Robert, I'm concerned that you caught COVID on a plane. So I want to hear about that. You talked about sort of safety theater, because I have a big question about when we're done with vaccines. We're done with the first round of vaccines, what's going to happen next in society. So, Rosemarie, why don't you say a word or two more about what you started with around J&J, what your feelings are about the sort of vaccine pause for what seems to be an incredibly small number of questionable side effects. So. Yes.
So, just to put I'm not an MD or a scientist. So it feels like an extreme abundance of caution that's going to have an incredibly chilling effect. And so it's sort of like you've always got to weigh relative risk. And when what we're working with folks on now is a communication strategy to say that, any vaccine is a good vaccine, just go and get vaccinated. This completely flies in the face of it. And I think a very stark, contrast I saw was just thinking about beyond the US, how far behind so many other countries are, even in Europe. I mean, we're proceeding at a decent clip here, but countries, that are developing countries in particular are struggling and are going to need this even more. And so the kind of ripple effect when you think about that is deeply concerning in terms of slowing down supply. And again, this abundance of caution for what seems, as you say, like incredibly small numbers versus the huge risk if we don't start to get a lot more people vaccinated worldwide.
Yeah, I know. I had a brief conversation with one of my colleagues in Japan last night, who was saying that a lot of the nurses and doctors doing the vaccinations in the nursing homes in Japan have not vaccinated themselves because they don't have enough supply. And somehow how the Japanese government dealt with Pfizer and Moderna, they didn't get it right, whereas the US did. But I don't know.
And along with the medical side, as we've all seen, you marry then the economy, like people I'm in touch with, are still in huge lockdown. We're rebelling in the US against lockdown, but in other countries, the lockdowns are very severe. And so how in the heck are they supposed to keep going? I mean, this is not sustainable.
And there was like a riot of young people in Belgium and in Canada. And yeah, I agree. Robert J, I'll pick on you two because you have the MDs after your names. Well, Jell's actually got his on the screen, but what do you think about this pause to the J&J vaccine? Do you think it's prudent? Did the CDC do the right thing? Do you think the ripple effects are going to actually be worse?
I can go first. So from what I understand, I think it's essentially one case in a million, right, of these venous thrombotic events that they've had. And a guy named Ashish Jha, who is the dean of the Brown Medical School and who is actually my classmate at Columbia undergrad.
We can't talk about Ashish Jha because he spells healthcare with one word. I'm kidding. Go on.
Wait a minute, I got to go. So do I.
But in any case, Ashish made the point that there are many things in healthcare, many drugs that we take that have higher risk of thromboembolic events, like birth control, right? 1 in 1,000 women will develop DVT as a result. So I think he said that the risk is not that great, but there is the reality of, how unlikely this is versus the headline. And I think a lot of people are going to be spooked by J&J. I was actually a proponent of J&J. I got my second Moderna 2 weeks ago, but I was advising friends that if you can get a J&J, it's a one-time shot. You should just go and get it done if you can get an appointment. And I think that's going to be a very difficult sell going forward. That said, from what I've read, Moderna and Pfizer have enough to have capability to increase production so that they can basically vaccinate every American who wants to be vaccinated. I think the greater concern is going to be the significant number of people who are vaccine resistant in the United States. And I think that is going to be a very big problem. That's going to be very hard to solve.
I want to get to that. I want to get to that just in a second. Robert, do you have a comment about the J&J one? And
I do.
Then I want to talk to you about the airplane.
Sure. Yeah. So the issue is a little bit more complex, I think, than the numbers that are being thrown around. This is a phenomenon that's only been seen in relatively younger women. So if we were to apply the Pareto 80-20 principle, we'd say, how do we vaccinate that group with Moderna or Pfizer? And reserve, because this is being seen in all the adenovirus vaccines. Now, why is it being seen in the adenovirus vaccines? Because there's probably something about the adenovirus, even though the two adenoviruses used in the AstraZeneca and the J&J are very distant from each other. But there's probably something there. But that's also what allows these vaccines to be less expensive and to be easy to transport at reasonable temperatures. So it is a trade-off sitting there. Where I disagree with a comment that was made earlier, this is really a political issue. It's not a medical issue. The medical risks in all of this are very, very small. The political risks are, how do you get people to have trust in the government? How do you get people to not have vaccine hesitancy? How do you have people to be willing to take the vaccine that's right for them, not the one for someone else? There are all of these political issues. I have a podcast called Coronavirus, The Truth, that we explore this on. I think at this particular point, the hesitation is less about the medicine and more about the politics and the social and the psychological issues that result. Rosemarie is very right. The big issue is, how do we vaccinate 7 billion people? And we're not going to be able to vaccinate them with an RNA type virus like Moderna or Pfizer. The AstraZeneca was the right solution. And I fear right now that it's not going to be implemented because of all the psychological conversation that's around. And I think that people have not figured out how to address this psychologically, politically, socially.
So let's talk a little bit about the assumption. Let's assume that we get, at least in the US, Moderna, Pfizer, those vaccines which apparently have no safety side effects, incredibly effective. Yes, you need to, I've had my first, I've had my second, but let's assume that we get that rolling in the US and we're all happy. Now we've got the problem that the last numbers I read was that 34% of Republicans and a bigger proportion of evangelical Christians don't want to get the vaccine. Let's assume that they're now no longer emergency use, but they're fully approved by the FDA, and we're down the path, and they've been shown to be safe in a gazillion million people, and it's all good and they're effective. What do we do about that big lump of people who say that they don't want to get the vaccine? Is there a persuasion solution? Are we going to slowly see those numbers come down as people get better? Is it okay to do we get to herd immunity without them? Or do we have to do something else? What do you think the next? And I want you to say, before we get there, Robert, I want you to tell quickly the story about the plane ride, because, it kind of indicates what you call like safety theater versus, safety reality.
Let me reverse. Let me just respond to the question first.
Yeah.
That's okay. And I'll tell the story. So the issue that we have to deal with is mutant variants. Because if this virus mutates, it already has either one or two, it's three different mutants, the one for Great Britain, South Africa, and Brazil, plus other ones, but two called protein changes as a result of the mutations that occur in the nucleic acids. If that progresses in a way to make the vaccines not effective, we're going to have a new set of problems sitting there. And that herd immunity is not just the United States, because the variant can happen in another country and certainly be brought over here, and we're unlikely to be able to protect against it. That, to me, is the biggest issue. What to do with the people who don't want to be vaccinated in terms of their health is a different ethical, moral issue. Should we be protecting them from their own decisions, or should we not be? I think the biggest question that's being raised, and why herd immunity is discussed so often, is that as long as this virus keeps replicating, it's going to have random mutation changes. Most of them will disappear because they don't make they don't make the virus more powerful or easier to transmit. But the ones that make the virus easier to transmit, they're going to rise. It'll be exponential, as we saw early in the pandemic, and that is the big challenge for the United States. But the question you have is, I was flying from San Diego back to New York, and I got on the plane and I sat down, and the woman behind me was coughing, mask was off, she was flushed in the face. I've been vaccinated. I'm a physician, so I've been vaccinated, but I knew that around me were a lot of people who were not vaccinated. There was mothers with kids. There were people who were clearly disabled. There were a lot of people there potentially at risk. So I went to speak to the stewardess. Now remember, when you get on the plane right now, what do they hand you? They hand you this alcohol wipe. It has nothing positive preventing disease. First of all, the plane's been cleaned over the night, so there's no bacteria, no viruses sitting there. And the newest studies coming out of the government show that this is not transmitted by the fold down tray in front of you in your seat. It is transmitted through the air, through the virus that gets coughed up there. And this woman coughed for 5 hours. Now, I spoke to the flight attendant, and I said, why don't you move her to another row? Why don't you call ahead so she would be able to be seen by health officials when she got off the plane? Oh, when she goes to the lab and gets tested, they'll notify everyone. So she's not going to the lab. And by the time they notify them, it's going to be too late. And nothing happened. We got off the plane. She did nothing. We went off the plane. There was no one there. And I was making the point that what the airlines want to do is to figure out how they can make passengers feel safe, not necessarily be safe. And today, people probably saw that the CDC has shown that by having middle seats empty, you lower the transmissibility by 50%. And the chances that the airlines are going to leave those middle seats empty is 0. This is not about how do we save lives. This is about how do we create a sense of safety around that. And the only good part about my publishing this story, which had 250,000 readers, was I got a note from a flight attendant who said, after reading your article, we insisted that the captain radio ahead and that assistance be given. And this time, when the patient got off, they were met by a health official. If you had not written that article, we never would have had the courage. That is what this is about. It's not about creating true safety. It's about creating the appearance so we can get back to normal.
So that's fascinating, amazing story, and great response. So let's go back to the mutant part. I mean, my assumption as the guy who failed biology, in high school, was that if you get enough vaccination across the world, I know it's a massive technological problem, is that we get, you kill enough virus spread that the thing dies out anyway or becomes very minor, right? As opposed to if you allow people in any country, but to a significant proportion to not do it, there's enough people who can spread it that it can keep going, and then you can get mutations, and then we're all back in trouble again. So let's say we're now. What do we think as a panel? Maybe we should go around and do a vote of our star chamber here. Do we think that the government, after everyone's had a chance to get vaccinated, has been vaccinated, and we've done the outreach to the communities, and we've done mobile vans, and we've gone door to door, and all the stuff that I think we should do, that we're going to have to do in developing countries, the way that Larry Brilliant did it when he went door to door to do smallpox in India, and door to door in jails and God knows where else. After all that, if there's a big chunk of people who say they don't want to have the vaccine, can we start mandating it for things like employment, school, college, big open spaces like concerts, sports events? Can we do what the Chinese are doing with their kind of on the phone, making sure we have a passport? Is that possible in the US? And should we do it?
I'll take a stab. It is happening. I think my answer will be short. The government isn't going to do it. The political will and the votes are not there. What is going to happen is the private sector will do it because it's in their economic self-interest. Organizations, companies like airlines and hotels and cruise ships, they're going to be demanding your vaccine passport.
Yeah, I agree with that. I think I was reading an article today about how Georgetown is requiring students to come back to campus. They have to demonstrate that they've been fully vaccinated. And I think in that article they mentioned 5 other universities. So I think it's very difficult as Americans. We're so focused on our individuality. The more you tell many Americans that they have to do something, the less likely they are to do it. So I think that kind of persuasion only works against us. I think it's going to be private entities that say, hey, listen, if you want to participate, if you want to benefit from our service, you have to demonstrate that you're vaccinated. And I think if you can do that with enough of the private sector, maybe you can drive a change in behavior. But I do think that at the end of this year, at the end of 2021, if you told me that 30% of Americans are still not vaccinated, I wouldn't be surprised by that number, 30% of adults.
But Matthew, let me offer a little bit of science back behind it, if I could.
Sure.
So if we just talk about herd immunity, you have to start with what's called the R0. How many people are infected by one person? With this particular virus, it's about 3. So you have to get the operational R0 below 1, because once it's below 1, if I only give it to 0.9 on average, they give it to 0.8 to 0.7, and the virus disappears.
Nice.
So that's what herd immunity is about. And to do that with a virus that has an R0 of 3, you need to get 2/3 of the people, or approximately 200 million Americans, to either have had the disease or the vaccine. The problem with the viral mutants is that they have a higher transmissibility rate. Their R0 is going to be higher. I'm estimating it's somewhere around 5. Now you got to get to 80% of the population to be able to get to herd immunity to have it go away. However, the question is, why is herd immunity so important? Now, if this disease were only in the United States, we'd have to get our population immunized so that the virus would disappear in the United States. That's one viewpoint. How worried are we that it's going to be brought in from someplace else and start the process all over again? That's a consideration that exists. Why are universities requiring it? It's like a dozen or 2 already who are doing it. Because they know that if the virus replicates on their campus, they're going to have to go back to virtual learning. And they economically do a lot better when students are there paying fees to stay in the dorm rooms that are sitting there. Why are concert halls or airplanes? The same reason. But if you essentially say to people who are not vaccinated, you can't do all these things, and they still gather together and spread the virus amongst themselves, we're going to be at the same place. So I speak a lot about in the coronavirus, the truth. We just keep tripping over our own feet because we fail to identify what's the real question that's being asked. Are we trying to protect this portion of the population that won't do it? Are we trying to allow some privilege to those who will, excluding those who wouldn't? Are we trying to get to herd immunity? Are we trying to open the business? And my answer is, we haven't figured that out. We haven't even had those conversations. And if I were able to somehow access the president's ear, that's what I'd be saying. Tell me the destination, And I'll tell you the strategy and the incentives to get there. We haven't figured out that destination. And it's why we keep making mistakes again and again and again. And the same thing is true with the J&J or the AstraZeneca. We can go down the list of pieces. We have failed as badly as one can do because we've not applied basic business thinking to this particular pandemic.
Rosemary.
Right. Well, I think part of the problem, I mean, I love the idea of getting the president's ear, but as we've seen, we are such a states' rights kind of country that the president has limited actual ability. I mean, you say this is where he wants to go. He can't necessarily mandate how to get there. And, it's going to go governor by governor / in some places now it's county by county. It's like, I was talking to the colleague in Kansas and she's just throwing up her hands in despair because, let's just say the bluer counties in Kansas are still keeping the masks on and doing all this stuff. And the more rural ones are like, no, bring it on. And so the disparity there is just profound. And that's what we struggle with, I think, as a country,
But
not just in vaccine.
Yeah, I mean, you're dead right. But I mean, and God knows, Christy Noem in South Dakota seems to want to encourage, seems to have a death wish for her entire population. But at some point, right, don't we have to say this, that this is a war? We've created the weapon to win the war. And it's not like, in whether you liked it or not, in World War II, we conscripted every adult male. We put them in the army. We didn't give them, there was like no choice about some of this stuff. I don't see, given, especially, that we have to spread this worldwide, the vaccine, not the disease, it's already worldwide. I'm as socially liberal as you can get and don't believe in the government telling you what to do and all that kind of good stuff. But when we've got to kill this thing, I don't see an alternative to saying it's wartime. We'll give you every chance we possibly can to educate you and persuade you and cajole you and the rest of it in America, but also in other countries. But we're going to do it. I don't think the Chinese are going to sit around and say you can't opt.
The votes aren't there, Matthew. The votes aren't there.
The votes.
Well,
and
we'll see if there's another 2-3 years of this, and we have mutations coming in, as Robert said, from other countries. I don't know. I think how much longer can we go with this current lockdown when we have the solution sitting right in front of us?
Matthew, would you stop being rational, please?
I'm about to become, the rational dictator fascist, the not so benevolent dictator on this issue, but that's good. All right, well, we have come very close to the end of our hour. It's been a great conversation about a bunch of stuff. There's a bunch more we didn't get to. I will be interviewing Robert later about his book, which is nearly out when I finish reading it. When I get past the bit where both Semmelweis and Robert get carted off to the lunatic asylum. I don't know if that's I haven't got to the end of the book, Robert. You may not be in the lunatic asylum, but the way we always end this is with a little quick go around to see what people are looking for in the next couple of weeks, what they're expecting to see, and any wild cards that might come up that they're worried about. So let's go around, and I will start with you, Vince.
Yeah. Okay. So this week, Senators Ted Cruz and Josh Hawley are contemplating removing the antitrust protections in Major League Baseball. So you may ask, how does that relate to healthcare? Well, let me try and draw the dots here. Why are they doing?
You only have 34 seconds.
Okay, they're doing this as backlash against the city of Atlanta getting rid of or Major League Baseball drawing out of Atlanta, which is backlash to the legislature in Georgia, which passed the voting rights legislation. We saw an ad a couple of days ago, hundreds of companies in the New York Times supporting the voting rights legislation. My question is real simple. Is this a blip on the radar screen, or is this truly a shift in corporate America becoming not so much Republican and much more Democratic? And what might this imply for the passage of healthcare legislation in the future, such as single payer or the public option? That's something to watch, I think. Is it a blip on the radar screen, or is it a permanent shift? And I think I have 4 seconds left.
Jail.
I think, building on the political discussion, I think, the Biden team has shown that they are prepared to move legislation ahead without any semblance of bipartisanship, and I don't know if you've seen McConnell held a press release or had a press conference yesterday where he was whining bitterly that he's not being involved in the process. And I think that that's the model that I think Biden is going to be moving forward with. And I think that as I think about healthcare legislation, I think you may see a strong push for legislation that passes without any Republican support, and legislation that is, as a result, much more progressive, let's say around things like Medicare expansion, Medicaid expansion, things like that. Hopefully things around, reimbursement for telehealth. And I think we may, although many people tend to think of Biden as a moderate, I think the functional expression of the policies coming out of the Biden administration may actually be very, very progressive.
And let's not forget there's $400 billion in caregiving dollars in the Jobs Act, which is now being called the Infrastructure Act and has to only be roads and bridges, according to the Republicans. Rosemarie.
Yeah, so I agree with Jean-Luc. I think that's fascinating to watch how progressive the Biden-Harris administration is moving to being, and yet Biden doesn't, present just physically as when I think of the young people who are like, I'm voting for Biden, he's not a progressive. And it's like, okay, close your eyes, but listen to what they're actually doing. I think it's really fascinating. But at the same time, as I said, we have the issues with the states and, those last states, the dozen that need to do Medicaid expansion, and even those that supposedly did, that are facing now like resistance in the legislatures. It is vital that we deal with the voting rights stuff, because the only way we can get to some of this actual healthcare expansion, at least with the vehicle we've got, which is the ACA, is we've got to solve this thing at the state level. And we can't ignore that. So they're very interconnected. And that's not just a next week issue. This is like what we've got to pay attention to for the coming months.
Robert, what are you paying attention to in the next couple of coming weeks, coming months?
I think that people need to remember that much of this legislation can only get through on reconciliation as a majority vote. And the two things that to me will be very fascinating, whether Biden pushes to make filibuster more difficult or make it outlawed completely through Congress. And number two, whether he looks to add 4 justices to the Supreme Court. I think that these two factors are going to have massive impact across time. And the other thing I'll look to, Matthew, is to see how many of your viewers go to robertpearlmd.com to be able to order the book on caring, how the culture of medicine kills doctors and patients, and get the freebies from this book, All Profits to Doctors Without Borders. Thank you so much, Matthew.
All right, well, it's been great having Robert on the show. So I want to wrap up and thank everyone for coming on. I guess my sort of thing that I'm looking is last week Jeff threw in a wild card, which is Jeff Gosling threw in a wild card. Sorry, 2 weeks ago, which is the result of the George Floyd trial, and how quote unquote a bad outcome there might really change the political conversation, set off rioting, and God knows what else. And we've seen a little bit of that in Minneapolis already. So that's something we've got to look on, because these things can knock legislation, vaccines, everything can get knocked away. The other thing, and I was a little worried about China last week. I'm not quite so worried about China because the Taiwanese don't think they're going to invade. I'm pretty worried about Russia, though, massing troops on the border. And you're seeing this stuff happen, and we know how presidencies, administrations, and world politics can just blow up domestic stuff. Go back to the Gulf War in 1990 and Iraq and Australia. We're this week getting out of Afghanistan, or planning to get out of Afghanistan finally after 20 years of doing God knows what there. And it seems to me that I'm just concerned about some of these wild cards, because the world is still going on while we're all focused on fixing COVID and doing the healthcare and buying Bitcoin at $62,000 or whatever. So that's my one to watch. All right, so I'd like to end the show as ever, thanking very much to my panelists. Come on, there we go. I had Rosemarie Day, all the way from Massachusetts. Vince Kuraitis, a consultant policy analyst from the wilds of Idaho. JL Neptune, and still has never left the island of Manhattan. and Robert Pohl from Connecticut, author of Uncaring. Robert, we'll come back and we'll have a longer discussion actually about the book in a few weeks. It's published in a month or so. But I really want to thank you very much for your time and attention, for your time and your participation today. Thanks to everybody for watching this. We'll be back with the THCB gang with episode 51. We've really done this thing for a damn year. It's incredible. Which will be next Thursday, same time, same place, 1 p.m. Pacific, 4 p.m. Eastern. Until then, thanks very much for watching and listening.